Okay, so I think most of you know me, but I'm Val Brule. I'm going to be the host today for today's PICU educational rounds. And just before we get going, a few housekeeping things. You can write questions for our speaker in the box, in the chat box. You can write them directly to me if you prefer to remain anonymous. Or you can, at the end of the talk, just turn on your camera and your microphone and ask a question directly. Before we begin, I'll do a land acknowledgement. The University of Manitoba is located on the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the national homeland of the Red River Métis. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnership with the Indigenous communities in a spirit of reconciliation and collaboration. And today I'm coming to you from Vancouver Island. So just want to acknowledge different people who have lived here for a long time, including the Lekwungen people, the Tasuk, the Alwa Kalam, and the Maka, as well as the Beecher Bay people. I really never feel comfortable just making a land acknowledgement because I think it's more important, or it's always more important, the reflection part. And so today, as we're talking, just to always think about how can we apply what we're learning to our Indigenous patient population? How can we use the knowledge we're gaining in a way that we can collaborate with their knowledge as well? And with that, I just want to introduce our speaker today. Really warm welcome to Maya Sadia Raimondo. She's a fourth-year pharmacy student, currently on elective rotation at the Children's Hospital, being supervised by Leah Pritchard, many of you who know through as a PICU pharmacist. As part of her rotation, she's developing educational materials that highlight PPI prescribing trends and recommendations based on current evidence. So, welcome, Maya, and I'll turn it over to you.
Thank you, Val. So my presentation will discuss PPI prescribing trends at the Children's Hospital and the recommendations for proper PPI use in pediatrics. The objectives for my presentation.
Sorry, Maya, you have to share your slides again. I'm so sorry. They're not up anymore.
Okay.
Just didn't want you to get too far. No problem.
You know how it's been unusual?
Just some technical difficulties, but it'll be good. We had them working a moment ago. Sorry, everyone. Okay, perfect. We can see your slides now.
Thank you so much. Okay. So the objectives for my presentation are to present the findings from a recent research project that was conducted by previous pharmacy students that looks at PPI prescribing patterns at the Children's Hospital and see if they align with current recommendations. Then I'll discuss some risks associated with PPI use and review current recommendations and evidence for appropriate PPI use in pediatric patients. Starting with the research project on PPI prescribing trends. The primary objective for this research project was to determine whether usage of PPIs in the Children's Hospital aligned with current pediatric prescribing recommendations by assessing whether PPIs were prescribed for appropriate indications and durations. The secondary objectives included assessing PPI duration in relation to other drugs of interest and mechanical ventilation, quantifying proportion of hospital stay where there was an active order for PPI, and determining the financial impact of PPI use on the healthcare system and patients and caregivers. This was the inclusion and exclusion criteria for the study. Inclusion criteria was patients less than 18 years old admitted to the PICU medicine or surgery wards and having an active order for a PPI and being admitted from January 1st, 2018 to May 1st, 2022. Exclusion criteria was patients seen only in the emergency department, patients admitted to the NICU, hematology or oncology patients, and patients with a PPI as a home medication. A convenience sample was taken from the PPI orders that met the inclusion criteria, and that left us with a sample size of 87 hospital visits after removing visits that met the exclusion criteria. To assess whether prescribing trends at the Children's Hospital aligned with current recommendations, the documented indication for the PPI therapy was recorded and compared to this list of indicated medical conditions and either classified as appropriate or inappropriate, whether it matched with any of the conditions on this slide. This list includes GERD, H. pylori, and erosive esophagitis, to name a few. Duration of PPI therapy was also classified as appropriate or inappropriate in relation to the indication it was prescribed for. One of the secondary objectives was to assess PPI duration in relation to stress ulcer prophylaxis due to mechanical ventilation. To do this, the start and stop dates were recorded and compared to see if PPIs were stopped. Similar to assessing PPI duration in relation to mechanical ventilation, the study also considered use of PPIs alongside certain medications, or they called it drugs of interest, for gastroprotection. This was also assessed by recording and comparing start and stop dates of PPIs, and also the medication it was providing gastroprotection against. Some medications include NSAIDs such as ibuprofen and high doses of aspirin and corticosteroids. So when assessing whether PPIs were prescribed for appropriate indications, 4 out of 87 hospital visits had an order for a PPI with an inappropriate indication. 2 of these patients were on the medicine ward and 1 each on the surgery and PICU. And when assessing whether PPIs were prescribed for appropriate durations in relation to their indication, 22 out of 87 hospital visits had an order for a PPI that was continued for an inappropriate duration. This was most frequently seen in the PICU at 34.8%, then the medicine and surgery wards. Based on these findings, PPIs are, for the most part, appropriately prescribed when there is a clinical indication. However, problems arise when inappropriate continuation of PPIs is around 25% of the time, PPIs were continued unnecessarily. This highlights the need for more frequent and consistent reassessment of PPI therapy and deprescribing when ongoing use is no longer needed. For the secondary objective of assessing PPI use in relation to mechanical ventilation, 8 patients were ordered a PPI for stress ulcer prophylaxis. 2 of those were appropriately stopped once extubated, and 1 was discontinued prematurely. And 5 were continued inappropriately after extubation, with a median of 13 days and range of 4 to 5 days duration following extubation. And in relation to drugs of interest, 31 patients were started on a PPI due to either starting scheduled NSAIDs or high-dose steroids. 21 of those were discharged home on the PPI and the drug of interest. 10 of those were stopped in hospital, with 2 continued inappropriately in relation to their drug of interest, resulting in 3 and 31 days of unwarranted PPI use. And the last one was a drug interaction that was inappropriately managed for 6 days. So over half of the patients prescribed a PPI for stress ulcer prophylaxis were inappropriately continued on PPI therapy, showing that PPI use in mechanically ventilated patients is a problem area that we can address. While a smaller portion of patients taking drugs of interest were inappropriately continued on PPI therapy, this is also another area that we consider when we are reviewing recommendations. Other secondary objectives were to quantify proportion of PPI use to hospital stay, and they had a median proportion of 66.7% of the hospital stay having an active PPI order, but this ranged from 40 to 100%. Healthcare costs were also assessed, with median cost of PPI therapy at $3.95 per patient stay, but ranging from 15 cents to $10.81. Based on this finding, the healthcare costs for PPI treatment are fairly low. However, the 4 patients that were inappropriately prescribed the PPI, one One hospital significantly costs more than the others, costing the healthcare system $79.75. So while the financial burden on the healthcare system for PPI use is usually low, there was one instance of a relatively higher cost for PPI that was not appropriately prescribed in use. And along with the healthcare costs, we also assessed patient and caregiver costs, with 63 hospital stays resulting in a discharge prescription for PPIs, with an average duration of 57.7 days for those prescriptions. 30.1% of those prescriptions were for Prevacid fast tabs, which cost $84.68 per month. And across all PPIs, average monthly cost was $62.38. And of the 4 patients that were inappropriately prescribed PPIs, 2 of them received discharge prescriptions that would have cost them $92.95 and $124.78 if they were fully filled at a pharmacy. 12 of those patients were discharged with an inappropriate duration of PPIs with a median monthly cost of $84.68. And 10 of the patients did not have a specified duration for PPI use on their discharge prescription. These costs are more significant for patients and caregivers compared to the cost to the healthcare system that we viewed on the last slide. This is especially important when the PPI prescribed isn't indicated or shouldn't have been continued, as the patients or caregivers are paying for a medication that may not provide benefit and may even cause harm. So these findings emphasize the importance of reassessing the need for PPIs and deprescribing when appropriate, but particularly at transitions of care, like at discharge, to ensure that this doesn't happen and put any unnecessary costs on the patients or caregivers. And addressing these issues will hopefully prevent risks and reduce those costs. So the study discussed patient and caregiver costs as an unnecessary complication following inappropriate prescribing of PPIs. However, the risks of PPI use were not assessed in this study, so I'll be going over some of the risks of PPI use. One important risk of PPI use is fractures. PPIs are hypothesized to increase risk of fractures due to increased gastric pH, which decreases absorption of calcium and magnesium and causes hyperparathyroidism. This ultimately leads to bone resorption and decreased bone mineral density. One study found PPI use to be associated with increased risk of fracture during a mean of 2.2 years of follow-up, with a hazard ratio of 1.11, which is a fairly low increase in risk. And another study reports hazard ratios according to the cumulative duration of use, with 1.08 for less than 30 days of use, 1.14 for 31 to 364 days of use, and 1.34 for PPI use for a year or longer. This suggests that longer durations of cumulative PPI use increases the risk of fractures, with shorter durations, less than 30 days, having a minimal increase in risk, and that risk increasing with longer use. PPI use is also associated with increased risk of infections, including C. diff infection. Since PPIs increase gastric pH and slow gastric emptying, this allows C. difficile to survive and multiply in the GI tract. Another proposed mechanism involved the disruption of the intestinal microbiota, which increases unconjugated bile acids and promotes the germination of the C. difficile spores. One study found an increased incidence of C. diff infection with an odds ratio of 3, which is a significant risk. In another study, they found that recent use of acid-suppressing medications, which were PPIs and H2RAs, within 8 to 90 days of the study had a significantly higher risk of C. diff infection with an odds ratio of 8.02 compared to acid-suppressing medications that had been last used over 90 days before the study. When last used within 91 to 365 days from the study, odds ratio was 2.75. And when last used over 1 year from the study, odds ratio was 1.56. So it appears the increased risk of C. diff infection is still present after discontinuation of a PPI, but this decreases over time. Another infection associated with PPI use is community-acquired pneumonia. In vitro studies found proton pumps in the lungs and H2 receptors in the bronchi So similarly to how pH changes in the stomach can cause a disruption in the GI tract, they suspect that pH changes caused by the acid suppressing medications may disrupt the normal flora of the lungs. Other hypotheses include intestinal dysbiosis, or that disruption of the normal flora affecting the lungs, and acid suppressants affecting. One study found current PPI use to be associated with increased risk of community-acquired pneumonia with a hazard ratio of 2.05. Long-term use over 211 days was associated with greater risk of community-acquired pneumonia with a hazard ratio of 2.34 compared to short-term use of less than 31 days with a hazard ratio of 1.89. So similar to fracture risk, the risk of community-acquired pneumonia increases with long-term usage of PPIs. And just a little side note to talk about the association between PPIs and COVID-19 infection. A study from earlier this year found no association between PPI use and increased COVID-19 susceptibility for this. As discussed with fracture risk and the implications of PPI use on calcium and magnesium absorption, increased gastric pH due to PPI use can affect the absorption of certain micronutrients, which may lead to deficiencies. Other micronutrients potentially affected by PPI use in children include vitamin B12, iron, and vitamin C. However, there is no evidence of a duration or dose response effect based on current evidence. Studies that quantify the risk of micronutrient deficiencies in children are lacking, and even studies conducted in adults have conflicting evidence regarding the effects of PPI use on hypocalcemia, hypomagnesemia, vitamin B12 deficiency, and iron deficiency. Finally, allergic conditions including asthma, atopic dermatitis, allergic rhinitis, and food allergies. One proposed mechanism involves a pro-inflammatory response that is T helper 2 cell dominated following disruption of the normal flora, which increases risk of allergic conditions over time. Another proposed mechanism suggests that impaired protein degradation from PPIs triggers an immune reaction in the intestine, leading to sensitization of these proteins and increasing the risk of allergies. As the use of acid suppressing medications, which is again PPIs, H2REs, was associated with increased risk of asthma with a hazard ratio of 1.44, atopic dermatitis with a hazard ratio of 1.12, and allergic rhinitis with a hazard ratio of 1. With one study reporting that this increased risk of asthma was observed regardless of the duration of PPIs. And food allergy was 1.7 times more common in children with a history of acid suppressing medication exposure than children without previous. Since we're considering the duration of PPI use, this separates the risks of PPI use into short and long-term risks based on the current evidence in children. When used for shorter durations, there was an increased risk of community-acquired pneumonia with a minimal increase in risk of fracture. And with longer durations of use, risk of fracture increases with the greatest risk past 365 days of use. Risk of community-acquired pneumonia similarly increased with longer durations past 211 days. And other risks such as C. diff infection, which reported risk relative to last PPI use rather than duration, allergies, and micronutrient deficiencies did not show any relation to PPI duration based on the current evidence available. So overall, short-term use of PPIs of 30 days or less has a lower risk of fracture and community-acquired pneumonia compared to longer durations. And when relating this back to the study on prescribing trends, PPIs were inappropriately continued in hospital for as long as 31 days in one patient, and discharge prescriptions with an inappropriate duration had an average supply of 57.7 days. So while these durations of inappropriate PPI use were shorter compared to the 365 days and 211 days where there's an increased risk of fracture and community-acquired pneumonia, there is still the potential for side effects, and the increasing risk of fractures and community-acquired pneumonia over time shows the importance of reassessing PPIs and preventing the long-term use when it's not needed. Now that we've identified some of the risks of PPI use as potential implications of inappropriate PPI prescribing, I'll go over recommendations for different indications based on the current evidence. First is recommendations for GERD based on the 2018 SCAN and NASCAN Joint Recommendation Guideline. They recommend a 48-week course of PPIs and at the lowest tolerated dose for children with typical GERD symptoms. Supporting evidence from RCTs shows the greatest symptom improvement occurs within the first 2 to 4 weeks of treatment. However, the guideline extends the recommended duration to 4 to 8 weeks instead, as some patients continue to have symptoms following the 2 to 4 week treatment period. But they still emphasize the shorter courses may still be effective or even preferred in some patients. The same guidelines have recommendations for erosive esophagitis. They recommend PPIs as first-line treatment for reflux-related erosive esophagitis in infants and children with GERD. Rates of healing were high with PPI treatment compared to H2RA treatment at 12 weeks. Evidence in children is low, but adult data similarly shows that PPIs are superior for erosive esophagitis. However, this guideline does not provide further recommendations for specified dosing and duration of use, aside from the supporting evidence assessing PPIs at 12 weeks. So looking at available primary literature for children with erosive esophagitis, 2 studies report healed erosions after 8 weeks of treatment, and the most recent study published in 2015, they found that 89% of patients experienced resolution after 8 weeks of treatment with esomeprazole. In the older study published in 2010, all 4 patients included in the study with erosive esophagitis had healed erosions after 8 weeks of pantoprazole. Therefore, the primary literature supports duration of 8 weeks for the treatment of erosive esophagitis in children. The SCAN and NASCAN also have an H. pylori guideline where they recommend antimicrobial susceptibility testing to guide triple therapy, which includes high-dose PPIs twice daily and amoxicillin for 14 days to maximize the eradication rate. Supporting evidence shows that high doses of PPIs taken twice daily increases efficacy of triple therapy, and 14 days of treatment was superior to 7 and 10 days based on adult data. As a side note, clarithromycin as part of triple therapy was the standard regimen recommended in the previous guidelines, but they no longer recommend it if their resistance towards clarithromycin is unknown, which is why they only specify PPIs and amoxicillin as part of their recommendation for triple therapy. For children with eosinophilic esophagitis, the SCAN 2024 guidelines recommend PPIs for a minimum of 8 to 12 weeks to induce remission. Many studies support this recommendation, with 68.6% having histological response, specifically 47% with a complete response and 21.6% with a partial response after 8 weeks of PPI treatment. However, higher remission rates were observed in those on a longer treatment duration of 12 weeks compared to 8 weeks, hence the recommendation ranging from 8 to 12 weeks. And for maintenance of remission in children with eosinophilic esophagitis, this guideline recommends PPIs for at least 1 year and PPI responsive children, meaning children who have achieved remission with PPIs. PPI treatment of at least 1 year at half the dose initially used to achieve remission was effective in maintaining remission in children that responded to PPIs. 70.1% were in histological remission and 86% remained asymptomatic after 1 year of treatment. Some patients continued treatment for a second year at a decreased dose, and 92% remained in histological remission. The study didn't provide an explanation as to why some patients were tapered to a lower dose for that additional year of treatment. For treatment of upper GI ulcers, there's not much evidence regarding PPI use for this indication in children. However, the adult guidelines recommend high-dose PPI therapy, suggesting 80 milligrams for a bolus dose, followed by 8 milligrams per hour infusion, for 3 days following the successful endoscopic hemostatic therapy of a bleeding ulcer. Supporting evidence shows that PPIs reduced further bleeding with relative risk 0.43, mortality with relative risk 0.41, and surgery with relative risk 0.42 compared to placebo or no treatment. There was no difference in efficacy found between continuous and intermittent PPI treatment. So if intermittent PPI treatment is used, doses of 40 milligrams 2 to 4 times daily, administered orally or intravenously, was suggested. Barrett's esophagus is a condition where PPIs are typically going to be used long-term, so this may not be relevant in terms of what we were talking about with the study and how we're more concerned about duration of use, but also discuss the current recommendations for this condition. There is also minimal evidence for the use of PPIs in Barrett's esophagus in children. The adult guidelines recommend long-term treatment with at least once daily PPIs, with supporting evidence observing a 71% reduction of high-grade dysplasia or esophageal adenocarcinoma, which are complications of Barrett's esophagus. This guideline also recommends considering higher doses if required. However, there's unclear benefit for higher PPI doses in Barrett's esophagus. Zollinger-Ellison syndrome is also typically used for PPIs are also typically used for long-term. So it's similarly to Barrett's esophagus. It may not be relevant in terms of what we discussed from the study. And there's also minimal evidence for use of PPIs in this condition in pediatrics. Adult guidelines recommend long-term PPIs at high doses, with one study observing all patients included in the study to have control of acid secretion within 3 visits or 18 months after baseline evaluation. Again, the recommendations for upper GI ulcers, Barrett's esophagus, and Zollinger-Ellison syndrome are based on studies done in adults, and all dosing recommendations are meant for an adult population. Earlier, we identified stress ulcer prophylaxis due to mechanical ventilation as a problem area based on prescribing trends, as 5 out of 8 patients on PPIs for this indication were inappropriately continued on that medication. Information on PPI use for stress ulcer prophylaxis is very limited. One RCT recommends stress ulcer prophylaxis be limited to mechanically ventilated children. They found no significant difference in bleed risk between the prophylaxis group and control group at 27.8% and 26.4% respectively. They suggest PPI use in mechanically ventilated children due to mechanical ventilation being an independent predictor of GI bleeds, and they believe that warrants the use for PPIs as stress ulcer prophylaxis. And this RCT discontinued omeprazole when patients improved, which they defined as not requiring vasoactive medications, decreased ventilatory support, and enteral bleeding. For drugs that are often taken with PPIs for gastroprotection, evidence for PPI use in children is also limited. A review done in adult patients recommends standard doses of PPIs in patients taking NSAIDs that are also at risk of upper GI complications. Studies included in the systematic review and meta-analysis that showed PPIs were more effective at preventing low-dose aspirin GI bleeds and ulcer formation compared to H2RAs, as patients on H2RAs had over twice the odds to experience GI bleeds and ulcers compared to patients on PPIs. In patients taking steroids with risk factors for GI bleeds, PPIs are recommended at standard dosing once daily. Correlation between PPI use and reduced risk of upper GI bleeds was not statistically significant, while correlation with H2RAs was not. Finally, this position paper regarding antiplatelet and anticoagulant use recommends PPIs and single antiplatelet therapy with risk factors, dual antiplatelet therapy, dual and triple antithrombotic therapy, and single anticoagulant therapy with risk factors. A meta-analysis of 10 RCTs found that PPIs decreased risk of low-dose aspirin-associated upper GI ulcers by 84% and bleeding by 73% compared to the control. In patients on dual antiplatelet therapy, PPIs are also reduced GI bleeds by 64% compared to the control. And this position paper states that standard PPI doses were the most effective for gastroprotection in patients treated with oral anticoagulants. Again, evidence for PPI use alongside these drugs is limited in children, and all dosing is meant for an adult population. So far we reviewed PPI prescribing trends at the Children's Hospital and identified that inappropriate durations of PPI use needed to be addressed, particularly in patients requiring PPIs for stress ulcer prophylaxis due to mechanical ventilation. We also discussed how inappropriate durations of discharge prescriptions of PPIs led to unnecessary patient and caregiver costs. Along with these unnecessary costs, inappropriate PPI use, whether not prescribed appropriately, or not deprescribed at the right time, puts patients at risk when they are not shown to provide benefit. After reviewing current recommendations and evidence for PPI use in each indication, this all emphasizes the importance of reassessing PPIs and monitoring patients to ensure that these medications are still indicated, and if not, they should be deprescribed, which is the last thing I will be covering. Evidence of PPI deprescribing in children is very limited, so these are the current recommendations for adult patients. To start off, these are some indications where deprescribing of PPIs may not be beneficial. One review on PPI deprescribing suggests that patients with complicated GERD, such as history of severe erosive esophagitis, esophageal ulcer, or peptic stricture, should generally not be considered for deprescribing unless the benefits and harms have been weighed and discussed with the patient. They consider some conditions like Barrett's esophagus, eosinophilic esophagitis, and idiopathic pulmonary fibrosis to be at greater risk of harms if PPIs are deprescribed, so they similarly suggest that deprescribing should not be considered. And when considering methods of deprescribing, this review recommends either dose tapering or abrupt discontinuation. However, it should be patient-specific and consider any rebound upward GI symptoms that may occur. The recommendation is supported by one trial that found no significant difference in the likelihood of remaining off PPIs and being symptom-free at 6 months between tapering over 3 weeks, which had a 31% likelihood, and abrupt discontinuation, which was 22% likelihood. Patients included in this trial took PPIs for at least 8 weeks. And in terms of recommendations based on duration of PPI use, deprescribing.org suggests tapering or abrupt discontinuation in adults with resolution of upper GI symptoms and a minimum 4-week course of PPI treatment. There are no recommendations regarding deprescribing in those with PPI treatment shorter than 4 weeks. This would be relevant for indications such as H. pylori or shorter-term stress ulcer prophylaxis. There is limited evidence indicating that patients on longer durations of PPI are more likely to experience rebound symptoms when deprescribing PPIs compared to those on shorter durations. And there's also limited evidence quantifying a duration when rebound symptoms present a significant risk. So considering this and the previous slide suggesting there is no significant difference in symptom recurrence between tapering and abruptly discontinuing, PPIs can similarly be tapered or abruptly discontinued in patients on shorter durations, less than 4 weeks. And that is all I have.
Awesome. Great job. Thanks. That was really a great overview and summary of a lot of work that was done. Um, we'll open up to questions now. If anybody has any, you can put your cameras on or ask them. I don't see any in the chat yet, but I'll start. Just wondering from the data that you presented in the beginning, it was looking at inappropriate prescribing, but did we also look at failed or like misprescribing of PPI when it was indicated to be given?
Like from the start, it was not prescribed for a proper indication.
Yeah.
Yeah, that was one
Oh,
of the
maybe I
primary.
missed that. Sorry.
That's okay. You can go back. It was a pretty small number of patients, so it wasn't the focus of my presentation. There were only 4 out of the 87 patient or hospital visits that were not appropriately started on a PPI.
Oh, I thought that was okay. It was they were started a PPI and it was inappropriate. Well, yeah, what I'm wondering is was there did you look at patients who should have been started on it but were not?
I don't believe they did. No, they did not.
Okay.
Again, the study was done by the pharmacy students before me, and I don't think they did not.
No, okay. Okay. I was just curious because the one that I'm of course most interested in is like the mechanically ventilated patients, and it's actually not been my practice to put these kids on it just because stress ulcers seemed quite rare, or they are very rare in children. And I was thinking of the risk of other like worse infections, but it seems like based on what you're saying, maybe we should start prescribing them for those, like for any mechanically ventilated patient. Is that kind of what your takeaway is from that study?
My takeaway is mostly that there's not that much evidence, and
Okay.
their recommendation is mostly based off of the fact that in their study, they found that mechanical ventilation was an independent um, indicator for GI bleeds. So they felt that that was enough of a risk for them to start PPIs for stress ulcer prophylaxis in those patients.
Okay. Yeah, that's helpful to know. I know there was a big randomized control trial that just finished, or I'm not sure if it was an RCT, to be honest, but it would just finish in adults in 2024. They were just talking about it at our critical care conference. And in adults, they said that prescribing would reduce stress ulcers and clinically significant bleeds, but not change mortality. So I guess that would be a good starting point for us to think about whether we should give it to all mechanically ventilated children. Yeah, interesting. Okay, thank you. There's a question from Holly in the chat. So she's asking, was the inappropriate duration generally too short a time span, or did you also include those that were left on it longer than necessary?
So most of them were, I can go back to the slide as well. I guess
Yeah, it might
the
be that
only
slide that you're just
for
on. Yeah.
they only reported it for mechanical ventilation and those drugs of interest if they were used for too short of a time span or too long. For like the general ones that weren't under like these two indications, they did not report whether it was prematurely stopped.
Okay. Leah.
You want to mute Maya so I don't have something for feedback? Thanks. Sorry, we're in the same room. Um, just to speak to your comment about, um, no, we did not look at patients who should have had it prescribed and didn't, simply because the way that we did the study was to, sorry, hang on one second. Sorry, we're just sorting out our technical issues from being in the same room. Is that better? Oh yeah, wait. Okay.
Yeah.
Awesome. Thanks. So we didn't look at patients who should have had it prescribed and did not, simply because the way that we set up the study was to um, query our pharmacy software for patients that had an active order for a PPI within a certain time period. So we didn't capture like the negative prescribing kind of thing. So no, we did not look at those patients specifically in this study. With regards to the thought about prescribing them in all mechanically ventilated patients, I think it's interesting because I think our general practice thus far has been to not do that unless they have other risk factors. So I think like mechanical ventilation alone, as long as the patient is feeding, because we know that having enteral feeds seems to be a protective factor, um, we tend to not do it for that combination. But we tend to do it if they're mechanically ventilated NPO, pardon me, alone, and then definitely if they have other, if we put them on steroids or if they're
Yeah.
on vasopressors or kind of other things. So it's interesting to think about whether or not all of them should be on it. My sense is I wonder if they shouldn't because, for our very long-term intubated patients who are um, receiving enteral feeds for a long period of time, you're right, the incidence is very low. And so I really am not sure if that would overall, like for your kind of number needed to
Mm.
treat of like to prevent a stress ulcer, how many patients are going to have side effects. But that's my sort of thinking about that. But it's interesting.
Yeah, that's kind of my thought process too, is the risk of stress ulcers is so low. In chil I don't know the actual incidence to be clear. Like I couldn't quote the exact number, but in adults they have more than we do. So it seems to be maybe a practice that they are shifting to, but I don't know that there is a benefit. I think it's something we should think about and talk about more, and hopefully keep an eye on the evidence out there. So I think this is a good discussion point to bring to us. Um, I guess, yeah, it's also what are the negative side effects of prescribing it? That's the other question, but I'm not sure uh, that we like, I think we would need to have our VAP data a little bit more robust before we start it, if we were going to do it to test it out, because then we can make sure we weren't getting more VAPs or something at the same time. Yeah. Sorry, ventilator associated pneumonia. Um, for those who maybe don't know that. Okay. I see many other of your pharmacy colleagues on here. Does anybody have any other thoughts or comments on this?
I was actually hoping Maya could speak to something else too,
Yeah.
just to hopefully to get some more discussion going. Is um, Maya, what do you think if you see a lot of people in this room are a lot of the people attending are PICU and NICU pharmacists. There's a few other allied health professionals and a few ICU physicians in the room. So what do you hope is their major takeaway from this? What are like if you could tell people just a couple quick bullet points that they could like immediately turn around and integrate into practice, what is the major takeaway that you're hoping that they have from this presentation that you've done?
I think my main takeaway would, especially considering that duration of PPI use was our main concern based on what we found from the study. I'm thinking more focusing on deprescribing of PPIs and monitoring and that sort of pathway. So going more towards making sure we're reassessing PPIs and monitoring for any side effects and stuff like that.
If you want to emphasize deprescribing of PPIs for these ICU pharmacists, do you have any suggestions of how they could integrate that into practice? So if you have a bunch of ICU pharmacists in the room and your suggestion to them is to deprescribe PPIs when appropriate, are there any suggestions on how they could integrate that into practice? Like, practically speaking, how could they start? Uh, do you have any practical suggestions for when they could start considering that, or what types of things should start to trigger in their mind that deprescribing should be done?
I think keeping an eye on how long these things have been prescribed for, how long they've been on the PPIs, and if there's any improvement that they've seen, if there's any side effects that they're seeing. Also dosing as well. I know kind of talking about if tapering versus a direct or an abrupt stop is more appropriate, but just considering any dosing and stuff like that, those would be kind of at least some vague practical ones.
I think the tapering is interesting because maybe that would be something to consider if we have a patient for whom we stop the PPIs and then somebody says, oh, they seem reflexy, and then they just go right back on and then they sort of get left on forever. Maybe that's a trigger for us to consider like, oh, maybe we should put it back on, but at a lower dose and maybe consider trying like a bit of a taper to try to then discontinue it again in another week or something and see if that's effective. Mm. Something else that I know that you've highlighted, but didn't include in that answer there, I know that you've highlighted in your other materials that you're developing, is that I think transition of care is a really important time to consider this deprescribing, right? When we transfer patients from ward to ICU, I think that was something that you highlighted as a really important um, time where this type of deprescribing could be looked at.
Awesome. I don't know if anybody else has any other comments or questions. Okay, well, Maya, do you have any final comments you wanted to make to kind of round out your talk? Or you don't have to, but if there's anything you wanted to add.
I don't think so.
Okay, no problem. Well, we look forward. Thanks for all this work on PPIs. I think it's really important for us to consider. There's definitely some indications where sometimes we use it, I would say, based on preference of different groups too, sometimes. So those are interesting things like to maybe point to your education and keep talking about the evidence. And hopefully we can integrate some of this into the work that we want to start on ventilator-associated pneumonia uh, following, because I think that these would go together. Obviously, stress ulcer prophylaxis, but I always think of PPIs also in terms of the respiratory flora that we end up getting ventilator-associated pneumonias as well. So that'd be interesting to follow. Yeah, thanks for your presentation today. Really good job. And yeah, very good job. Good work. Great presentation. And with that, we'll end rounds for today. Thanks for everybody for coming. The next rounds is going to be December 20th with Dr. Brzezinski doing PICU point of care ultrasound discussion and talk. So great job, everyone. Or sorry, great job specifically, Maya. And thanks for coming, everyone, is what I was trying to say. Okay, good thing this is recorded forever. Okay, have a good day, everyone. Bye.